Hello, everyone. Good evening. I'm so excited to be here tonight. Our goal for today is to really discuss how we can raise the bar in taking care of our patient with Crohn's disease using evidence-based strategy and to improve patients' outcome. I'm Aline Charabaty. I'm a gastroenterologist at Johns Hopkins School of Medicine. I'm the assistant clinical director of Johns Hopkins Division of GI and the clinical director of the Johns Hopkins Sibley Memorial Hospital and director of the IBD Center here. I am delighted to be joined by two of my great friends and inspiration. Dr. Ed Loftus, he's a professor of medicine and the co-director of the Advanced IBD Fellowship at Mayo Clinic, Rochester. Hi, Ed. Thank you for joining us.
Hi, Aline. Thanks for having me. This is great.
And this is great. This is, I know we've been zoomed out with DDW all this weekend, but I feel this is a more intimate setting, so I'm excited about it. And we're joined by Dr. Maria Abreu, who's stepping like big feet now into the Twitter world. I've been trying to convince her to join our conversation, so I'm very excited for her to be here. She's a professor of medicine at the Martin Kessler Chair in Gastroenterology at University of Miami in Florida, and was recently received the AGA Research Mentor Award during DDW. So Maria, congratulations, so well deserved.
Thank you, Aline. It's wonderful to be here with you.
Absolutely. So we're going to start fairly quickly because I know everybody had a long day. I know I had a long clinic day. So we can go to the next slide. Do we have slides? To prevent disease progression and bowel damage and disability in patients with Crohn's disease, and how we can use clinical trial, evidence-based guideline, and comparative effectiveness research on approved treatment to appropriately position therapy for patients with Crohn's disease. All right, so in true Monday Night IBD fashion, we're going to step right into a case. This is a 47-year-old woman who presents with fatigue and mild iron deficiency anemia. She has a diagnosis of IBS diarrhea that was given to her a year ago. She had complained to her primary care doctor about intermittent abdominal cramps and diarrhea that come and go. There'll be a few days where she would not feel well, and then most of the time she'll be doing okay. But now she has iron deficiency anemia, so her primary care sent her to you, and you perform a colonoscopy, and you see deep linear ulcers in the right colon. The rest of the colon and the terminal ileum are normal. On biopsy, we have evidence of acute and chronic inflammatory changes. Upon further questioning, she has no extraintestinal manifestation of Crohn's disease, no weight loss. She's a social smoker. Her stool studies are negative for infection, including C. diff, and her CRP is elevated. Her albumin is normal, and her hemoglobin now is 12 on oral iron. You approach her about therapies, and from the get-go, she tells you, I Googled it. I do not want to be on a biologic. I'm really worried about biologic. I feel that my symptoms are fine. I'll be managing the diarrhea and the abdominal pain. I don't think this is severe enough to start a biologic, and I think this is relatively manageable. My cousin has Crohn's, and he has a really bad, he already had surgery, but I'm doing okay. So I want to bring back our panelists early in this and see, what are the things that strike you in this case? I think this is a common scenario that we see. I wonder how, you would approach this. How do you approach the conversation? What are the elements that you feel will be helpful for the patient to understand what Crohn's disease is and why it's important to be on therapy? And Maria, I'd like to start with you.
Well, Aline, this is very common, but it's particularly common that it's a woman to whom this happened, right? Because women more commonly have IBS, so they can get blown off and not, fully evaluated. I mean, now I think that doing calprotectin has become part of the standard for how you decide if someone actually has IBS as a point of stratification. So we kind of caused this problem because she got used to feeling like not well for over a long period of time. And so I try to get them to think back to what they felt like before they went to see the doctor in the first place with IBS. Try to elicit symptoms of fatigue, right? Because we know that that's very common, not just the iron deficiency anemia, but there's a level of fatigue that we still don't fully understand. Might be metabolite driven from the microbiome. So I try to get I get to get the patient to see that their quality of life is really impaired and that they've gotten used to this lower state of being. The other thing that I don't know that maybe we should dedicate some energy to is what the hell is on Google that scares all these people off from biologics, which has like been such a great advance, right? But it's somehow it's like become a 4-letter word, biologics on Google. I don't know. I don't have the time to be searching for all these things that go wrong when people go on biologics. I think that some of the most impactful things we do to get people's lives back is to give them a biologic, right? I think we all have that experience. So, I mean, I think sometimes I think we have to speak with confidence when we speak to patients about the safety. I know this will come up and you've organized a great program, but, speak with confidence about why they need to be on these things, even if we're not going to be autocratic, but there's a difference between being confident and speaking without giving them mixed messages and letting them make the ultimate decision.
I agree. And you bring up a very good point about delayed diagnosis, especially in women where symptoms are not recognized or not worked up appropriately. And a diagnosis of IBS in somebody who's in their mid-40s is unlikely. And it's something that we should reassess if there was no prior history. But I agree with you. I think biologic need a rebranding. I think we need a different name, something about biologic. We had a conversation on Monday Night IBD where people it brings back kind of like biologic warfare or it just has a bad connotation. And I often explain to patients that the reason, what they are, what kind of, how they are antibody and what kind of mechanism of action they have and how exciting it is that now we know how to target pathway of inflammation. And I also remind them that because they're protein, that's why their injection and infusion is similar to insulin and EpiPen. And people are familiar with the insulin and EpiPen, and suddenly it doesn't become more like a big deal about, the mechanism of administration feels like it's something, scary. Ed, what are your thoughts about this patient and how would you approach her? And what are the things in her history or in her apprehension that maybe help you determine what therapy do you think would work better for her, and how would you approach kind of a treatment plan with her?
So, when I heard the case at first glance, I thought, oh, well, she's a little bit older than average in diagnosis, and she's got colonic disease, so maybe it's low risk, but those deep ulcers worry me. And so I do think she's at a high risk just on that basis alone. And she's a smoker, social, but that could be contributing. I think you have to talk to folks in a very, just like Maria said, a confident way, but in a calm and compassionate way. And you're not being dogmatic, you're just laying out the facts, and I think you try to allay their fears. And I think sometimes, people just have a connotation from a biologic from seeing a TV commercial and all the side effects. And I think maybe educating them that there isn't just one type of biologic, there are others. And some patients are driven by efficacy. Like you can show them the results of Sonic and they're like, oh yeah, I want to be on combo therapy. But other patients are driven by safety concerns, especially I think in a newly diagnosed patient. And I think just the education piece of some of the other biologics is the way to go here.
I completely agree with you. I think it's important to understand. I often tell my patient, I understand that this is a new diagnosis, this is scary, and this is something new, and we're here to work with you. And I think that's very impactful to acknowledge that this is not an easy decision or an easy diagnosis to have. All right, so we're going to move forward, and I really all appreciate your points. I think you made amazing points, and this is what I'm going to take back to my clinic tomorrow. So if we move forward with the case and bring together the data that we discussed, if we can get to the next slide, please. All right. So, like we were discussing, Ed brought up that point that these are deep ulcers, so he's concerned about her, she's a smoker, etc. When we are assessing a patient who is presenting with symptom or flaring in clinic or in the endoscopy, we're really assessing them at a specific point in time. But the reality is that this is not an isolated event. This is an event that's representing a progression of the disease. With every flare, there is structural damage that occur that lead to development of complications complications such as fistula and stricture and the need for surgery. But also beyond the flare, so outside the flares, when the patient are feeling okay, like our patient feeling that in between these episodes of diarrhea and abdominal pain, she's feeling fine, she's managing, we know that there's active inflammation, asymptomatic active inflammation, if we, that is happening in the colon and that is leading to structural damage. So with every flare, but even in between flare, if we're not careful and monitoring our patient, if there's an underlying undertreated inflammation or untreated inflammation, the disease is progressing and we're having structural damage. So the idea here is that we have a very early window of opportunity in Crohn's disease to intervene with effective therapy and prevent disease progression. Once we have that first flare, and once we assess the patient, starting effective therapy and monitoring the disease and adjusting therapy to maintain disease and remission will allow us to prevent structural damage and progression of the disease. So the question is, who are the patients at high risk of developing severe Crohn's disease or complicated Crohn's disease? Next. So it's important to really identify who are the patients that could develop severe disease before they develop it, and to treat them before they develop severe disease. So I think the concept of, this patient was mentioning her cousin with Crohn's already had surgery, so it's justifiable to be on biologic. We really want to use effective therapy before we get to surgery, before there's a need for surgery, and before there's irreversible structural damage. Next. So who are the patients at high risk of developing complication? Let's talk first about low risk. Low risk patients with Crohn's disease that have a low risk of disease progression are those that have a low inflammatory burden. So you'll see small aphthous ulcers, there's a limited anatomic involvement, the CRP is normal, the albumin is normal, and they have no prior history of being hospitalized for Crohn's disease. These are also patients that have no structural damage, no stricture, no fistula, no perianal disease, no prior complication requiring surgery, and overall they have little symptoms and their disease has little effect on the quality of life. Our patients at high risk of developing complication of Crohn's disease are the opposite: high inflammatory burden, large and deep ulcers like we see in this patient, extensive involvement of the bowel, small bowel disease, upper GI disease, high CRP, low albumin. Patients who already have structural damage, whether it's stricture or fistulas or abscesses, patients who require surgery, patient with perianal disease or severe rectal disease, so at risk of developing perianal disease, and patients who have a high symptom burden and where the Crohn's affect their quality of life. Younger patients, smoker patients, these are risk factors, and later Maria will address with us, whether genetics also play a role in developing a complication in Crohn's disease. So once we identified who are the patients at risk, then we have to identify what is our target for those patients, right? We talked that we want to prevent disease complication, we want to prevent disability. So what are our goals with our patient? And for every one of the patients, it's important to define the goals of care. But in general, it is prevention of disease progression and disability because of the disease. And I would add, in that context, preventing the need for steroid and recurrent steroid use and all the morbidities that occur with steroid. So the treat to target concept involve treatment with a predefined treatment target, and then reassessing the effect of that therapy periodically. This is when we talk about tight control strategy. It's important to monitor our patient and reassess whether or not we're achieving the target that we set to achieve. And if we didn't, then we need to optimize or modify the treatment in order to achieve our target. And all these, our goals, our treatment goals, how we're going to monitor, this all needs to be tailored to the needs of the patient. And it's important to discuss with the patient what is our long-term plan, what is the short-term plan, and how we're going to modify things accordingly. And it's important to do it really by looking at the entire individual. They don't only have Crohn's disease, they could have comorbidities. You might treat somebody who's young differently than somebody who's had multiple surgery, than somebody who's older with multiple comorbidities. So it's important to adjust our target, our aim, and our strategy to the individual patient. So now that we have our, how we're going to select, we have a strategy, how are we going to achieve our target? What are our targets? So STRIDE that looked at how we should select therapeutic targets in IBD, we recently had STRIDE 2 being published, where our targets have moved from symptomatic response to symptomatic remission and normalization of CRP to a decrease in calprotectin to an acceptable range for Crohn's disease, and achieve endoscopic healing. In STRIDE 2, there are several additional elements that were added. In children, normal growth, which is very important. We know that patients, children with Crohn's disease can have delayed growth, delayed puberty, and that's poor bone health, and that is very important to look at as our target for our kids or teenager with Crohn's disease, that we want them to develop normally. The other thing that was added that I think is extremely important is restoring the quality of life of patients. Maria just brought up the issue of fatigue with inflammation. This is something we often hear from patients, but beyond controlling the GI symptom and achieving endoscopic healing, we want our patient to have a normal, productive life, and we want them to not develop any disability that prevent them to have this full life. So we devise a strategy. We have our targets. We understand that we need to do something early on, and like Maria and Ed pointed out, biologic have been the mainstay in treating moderate to severe Crohn's disease in an effective manner. And this is data looking at the early use of biologic, meaning using biologic within a year of the Crohn's diagnosis, and its effect on ER visit and hospitalization compared to patients that were started on biologic after a year from the diagnosis of Crohn's disease. And what you see here, so in red is the rate of hospitalization or ER visit in the first year, in the first year of diagnosis of Crohn's disease, and in blue you have the hospitalization and ER visit after 1 year of the diagnosis. So if we're looking at the graph on the left, this is our early biologic users, those that were started on biologic within a year of their diagnosis. And you see that on the long run, and long term, their risk of hospitalization and ER visit decrease. If you look at late biologic users, so those that were started on biologic beyond a year from their diagnosis, here, the risk of developing or of needing to be in the ER in the hospital doesn't change much compared to their first year of diagnosis. So this is interesting data, I think, that really highlight how early and effective therapy in Crohn's disease can really have a long-term effect on the patient Crohn's disease activity, progression, and need for hospitalization. Next. So we have our patients, we said we want to adjust therapy and goal, individualize this to the patient need and the patient disease characteristic. And the AGA put out a really nice paper on positioning therapy in moderate to severe Crohn's disease, really highlighting the importance of balancing the risk of disease-related complication, the risk of the patient to developing complication in the severity of the disease, and the specific risks related to the treatment. So this is what you want to balance, the risk of therapy versus the risk of leaving the disease untreated. If you have a patient with severe disease, again, we talked about the criteria for severe disease: high structural damage, high inflammatory burden, significant impact on quality of life. The first-line therapy is typically anti-TNF, infliximab or adalimumab for most patients. Whether or not you choose to use a combination therapy to prevent antibody development to anti-TNF, or based on sonic data to increase efficacy, that should be individualized to the patient. And for patients with very high inflammatory burden, patients in the hospital, high disease activity, perianal disease, severe extraintestinal manifestation, there is a preference toward infliximab over adalimumab, and a preference of combination therapy over monotherapy. In case the patient does not respond to anti-TNF or develop intolerance or loss of response, then we can consider either a second anti-TNF, depending on the situation, or a different mechanism of action. In patients with more moderate disease who are very risk averse, who have a prior history of infection, malignancy, advanced age, multiple comorbidities, and where really high safety is valued, first-line therapy for moderate disease will be vedolizumab, and a second line would be ustekinumab. For those that have a higher disease activity, it will be the reverse: ustekinumab first, second-line therapy either vedolizumab or an anti-TNF. So let's review quickly the data. We are all familiar with the data of Vedo and ustekinumab. I want to review them quickly. And the few things I like to highlight about vedolizumab is that, clinical remission and response at 6 weeks might seem low. So Vedo has that reputation to be slow to kick in. But look at what happens at the end of the year. 40% of patients are in remission. So what I like to remind people is that, Crohn's disease is not a 5K. I think Maria would appreciate that analogy. It's not a 5K, it's a marathon. So it's okay to have a slow start. The important thing is to get to a place of remission and to in a way that is effective and safe for the patient. So for a patient where vedolizumab is appropriate for the disease severity and disease characteristic, Vedo is an excellent drug. How about ustekinumab? And here again, we see a very good clinical response early on after the induction dose, the first IV dose. We have clinical response up to 55% and clinical remission of 35%. And at the end of the year, 50% of patients are in clinical remission. So again, excellent data with ustekinumab, and it has an excellent safety profile, also very comparable to what we see with vedolizumab. Next. So, we can't talk about treat to target without talking about CALM study. Again, most of you are familiar with the study where patients who are bio-naive and with moderate to severe Crohn's disease were randomized to either clinical management or tight control. What that basically meant is that everybody got started on the induction dose of adalimumab, and then depending on the circumstances, they were moved to adalimumab weekly or adalimumab weekly and adding an immunomodulator. Those in the clinical management, they moved to the next step in case they had symptoms or they require prednisone to control their symptoms. Those in the tight control arm also stepped up into the next therapy based on symptom or based on the value of fecal calprotectin and CRP. So even in the tight control arm, even if the patient was not symptomatic, but the fecal calprotectin was above 250 or the CRP was elevated, then adjustment to the treatment was made. And what we find here is that, more mucosal healing and steroid-free remission at week 48 happens with tight control monitoring as compared to the clinical management alone. So mucosal healing and steroid-free remission were higher in the tight control group compared to the clinical management group. And overall, the tight control group had fewer hospitalization, longer period of remission, and increased quality of life. Now, they did have higher costs due to monitoring. Checking fecal calprotectin or CRP periodically is associated with a cost. But if you look at the overall cost, in terms of saving ER visit and hospitalization and better quality of life, that can actually translate to being able to go to work and take care of your family and all the things that we want our patients to do. The tight control monitoring was a more cost-effective strategy than the clinical management strategy. And finally, in terms of long-term effect, if you follow patients who went into deep remissions, this is a blue line, compared to those that were not in deep remission, that was a red line. Patients who were on deep remission had a decreased risk of disease progression up to 3 years of follow-up. And what deep remission was defined as is that clinical remission of steroid and endoscopy, you have a CDIS score of less than 4 and no deep ulcers. So the question is, how often can we get people into deep remission? It's not that often, and this is I want to stop here and bring back our panel. This is not often. So even with the tight control group, we achieve deep remission, that holy grail of our goals, in around 40% of patients. And I think also it's very important, again, I always reemphasize that the deep remission meant a CDI score of less than 4 and no deep ulcers. So I think I would like to hear your thoughts on how much do you pursue that goal? When do you say this is good enough? When do you decide to switch therapy, or when do you decide to stay the course and say, you know what, I'm going to sit tight? And what kind of monitoring do you do in your patients where we didn't achieve that perfect deep remission, where we still see some areas of significant inflammation, maybe a few aphthous ulcers that are not significant, but maybe some areas where we had severe inflammation and now we have less severe inflammation. And would that make a difference if it's small bowel disease or colon disease? So I realize it's a lot of questions, but I think this is a perfect opportunity to have you both and hear your thoughts.
Who goes first, Aline?
You know what? Let's start with you.
No,
let's start with Ed. I'm going to alternate and be fair. I don't want to be accused of having a woman now and then we're keeping our men outside the loop. Ed, go ahead.
No, I think, there are a lot of good questions in here. And one of them, to your point, is that we can't always achieve the target. And then you always have to make this decision. Okay, well, how good is good enough? Or do we, I think simplistically, if you are on a drug where you haven't felt like you've maxed out the dose, if you haven't achieved the target of full endoscopic remission, then I'd be inclined to consider dose escalation. But that's definitely one of the holes in the whole treat to target hypothesis, is what's good enough to decrease these downstream events, and there's still holes in the data, and this is one of them. Is an SESCD of less than 50, if a decrease of 50%, is that good enough, or do you really have to get the SCSCD down to 4? I don't think we know. I think there's conflicting data out there. I think if the patient hasn't maxed out on their therapy, then you can max it out. But when you max out the therapy and they're clinically a lot better, and endoscopically they've had some improvement, then that's the trickiest situation.
So Ed, let me follow up on that before I turn to Maria. And because I always hear you saying the enemy of good is perfection. So I'm glad we started with you. So what would you be your strategy if somebody is feeling much better? They tell you, this drug changed my life. I'm feeling great. I can take care of my kids. I'm going to work. My joint pain is gone. I have good bowel movement. And then when you look at their colon or small bowel, you still see significant disease activity. You optimize the anti-TNF. Let's say we're on anti-TNF. Do you add an immunomodulator at that point if we have a good level? Do you feel that there's a synergistic effect, or are immunomodulator only increasing the drug level of anti-TNF? How would you approach that? Do you go by calm? Do we stay calm and proceed? Or, how do you assess? I mean, we're really trying also to keep our patients away from infections, and we know that combination therapy can increase the risk of infection. And I feel like if we're adding an immunomodulator to get better, then do we really withdraw it after that, or are we going to keep them on that forever? So I would love to hear your thoughts on that.
And there's no one easy answer on this. It's like the classic. So one of our attendings here is classic. The fellows used to joke because he would always say, well, it depends. And this is one of those, well, it depends situation. And I think, you look at the totality of the severity of their disease. And if they have severe disease, then maybe you're going to be more inclined to add back in the immunomodulator, especially if they're on an anti-TNF. I have to say that we're using way less immunomodulators for the non-anti-TNFs now. But I do think that back before 2007, when everybody got nervous about this stuff, we had everybody on combination therapy, and we just didn't see this same issue of people just burning through drugs. And so it really does have a significant effect on persistence of biologics.
Yeah.
Well, I do miss the 80s, so I think maybe we should go back to how we used to do it. I do miss that, but I think you bring a good point. I think sometimes by trying to be too safe, we're actually maybe burning through drugs and doing a disservice to patients. So, and I agree with you. I don't remember seeing horrible infections or my patients being in the hospital on combination therapy. I think it could be a select population that is, that could get sicker, where we want to avoid combination therapy. But I think in our young patients, I think this is something to reconsider. I agree with you. Maria, in your patients who did not achieve, perfect healing, but they're doing well, do you monitor them differently? Are these patients where, you really want to follow the calprotectin? Do you scope them more frequently? And is it different if it's small bowel disease, colonic disease? How do you approach that? And I would love to hear your thoughts on that.
Yeah, I mean, I think the first devil in the details about some of the data that you presented is that the patients that have the worst disease, the most extensive ulcerations, are probably the least likely to go into deep remission. Like they could have a significant improvement, but they're so far. It's like the same thing when we used to just base it on CDAI. Those people that had extremely high CDAIs were less likely to make it all the way to 150, but in a way they had the biggest delta, right? They had the biggest delta, and they got significantly better. The other wild card here is that I think some of our newer drugs might take longer to achieve mucosal healing, and patients seem to me to like have disproportionately an improvement in their general sense of well-being well before we're seeing the mucosal changes that we have. So I think there's still stuff that we need to learn, because patients, at the end of the day, I think I agree with Ed that if I find that someone is clinically better and their endoscopy is better, then I ask the question, what can I tweak? Is there a tweak I can make? Do I need to dose escalate them? But if it means that they're better and possibly even feeling normal, and I have to add now another drug, that now I have to take the risk of not all the risks that we just described, but the risk that that person is going to have a side effect of that drug, just that individual person. It's the thiopurines. We still don't have a test that we can order to make sure that they're not the pancreatitis patient, and they're not that they're not going to develop a fever. They're not, and of course, a lot of them will get fatigue anyway. So we have to take all that into account, because if you can't make a well person feel better, you can only make them feel worse by inheriting the side effects of the drugs. Yeah. So it would, and then I think, I only plan to do a colonoscopy if I'm going to make a change based on the results of that. So, for example, if I still need data, like I haven't optimized their trough levels, that and I could be here all night talking about proactively checking trough levels. And I've learned from Marla, I've changed how I do things. I'm now checking trough levels of infliximab before the third dose, and so very early on, so that we can intercept that 8-week gap where I think a lot of immunogenicity might occur in that first big gap that they have, right, when they've had the most inflammatory burden. So she finds that in children doing that, there's a much less likelihood of them developing, immunogenicity antibodies if she's very proactive in that initial window, and that fits my bias. And so I think we've learned some tricks that might allow us to avoid using the thiopurines as purely a way to avoid immunogenicity, even though I'm a believer these drugs work. I mean, we are from the 80s in a way, right? We know that these drugs do work, right? So I think that they can complement the effects of the thiopurine. By the way, I feel it can complement the effect of all the biologics we have. We just haven't done a sonics type study.
Right. I completely agree. I think it's important to have a plan, and I think it's important to readjust with time. I think just doing things one way and not learning from what happens with the patient and from each other is not the right way to do it. But I think sometimes it's important to look back. Like you said, the 80s were not that bad. And I feel like we've gone through cycles of, combination, no combination. And now with the new therapies, there's no evidence that combination increase efficacy. But I feel in some patients we need it. In patients who have failed multiple therapies, I think it's I can see the benefit of combination therapy. In patients where I'm using a drug that might not have effect on the extraintestinal manifestation as good as an anti-TNF, I've been using methotrexate a lot, and I found it very helpful. So Ed, I think Maria actually did a great segue into your next section, talking about proactive therapeutic drug monitoring and how can we optimize our therapies, because obviously there's a gap, and part of it, I think we've been discussing this for a few years now. How can we optimize treatment to make those that are having very severe disease, not responding to the standard dosing, do better? We know that those that have a milder disease are going to do fine. What about those that have more severe disease? So I'm looking forward to your section, and then we can talk more how you're doing your reactive and proactive therapeutic drug monitoring in your practice.
Does this mean that the hairstyle, like the flock of seagulls guys, is going to come back? That's what I want to know. Okay. So we'll have to get back to that in the Q&A. So next slide, please. So one of the concepts that isn't as well developed as well is the frequency of monitoring in the treat to target paradigm. I mean, when this all started out, we used to say, yeah, it's 6 to 12 months or it's 3 to 6 months, and it was all vague and unspecified. And I think one way to think about it is look at your patient, and are they a high-risk patient or a low-risk patient? In other words, what are the stakes if they fail therapy? So how many surgeries have they had? How extensive is their disease? The low risk patient is maybe somebody who's already been in remission for a year and at some point already had either radiographic or histoendoscopic healing, or their biomarkers are normal. They seem to be adherent to therapy. They're an older patient. And in that patient, yeah, you don't have to do the treat to target, the cycle of monitoring and adjustment as frequently. You can probably get away with every 6 to 12 months, maybe check biomarkers like calprotectin in between, and then scope if they have, an increase in symptoms. Whereas the high-risk patient is the patient who last time you looked still had endoscopic activity. Maybe you're worried about their compliance. Maybe they're a younger patient. That's a patient that you want to keep on a tight leash, so to speak. Maybe you're going to bring it back in 3 or 4 months. And again, have a lower threshold for scoping them. So I think the treat to target isn't just picking the target; it's deciding how often to check the target, and then how often to check the surrogate targets in between. Next slide, please. And so again, to optimize the outcomes in our patients, it's not one. There's no one miracle thing that we're going to do to optimize outcomes. It's really a series of all these things. And we already heard about recognizing and treating disease early, that window of opportunity, choosing effective therapies, choosing biologics that have actually demonstrated to work in randomized controlled trials. We've talked a little bit about treat to target and the frequency of monitoring. We're going to talk a little bit more about TDM and head-to-head trials, and then we'll go into some of this other stuff as well, the personalized medicine, and not looking just at medical therapy, looking at the bigger picture of lifestyle, diet, things like that. Next slide. So this is taken from the PANTS study. So the PANTS study stood for, I think, personalized. It's something about personalized medicine in anti-TNF patients. And this was a big multi-center UK study. It was prospective. There were over 1,600 patients with Crohn's disease who were enrolled. And these patients were followed very carefully. Blood samples were taken. Their clinical status was assessed. And here we're looking at a chart of infliximab on the left, adalimumab on the right. And this is the correlation between what the drug levels were at week 14 and whether or not the patient was in remission at week 54. And this is actually the flip. It's not remission. These bars aren't remission. It's not in remission. And you can see that generally the lower your drug level at week 14, the less likely you were or the more likely you were to be in non-remission at week 54. This held true for both drugs, and you can see that it sort of plateaued out once the drug level got to be about 7 for infliximab and about 12 for adalimumab. And so this is what they thought were the optimal week 14 cutoffs in this particular study. It's a great study. There's tons of data in there. They even did a little mini comparison of biosimilar infliximab with originator infliximab. There's interesting data on HLA markers. We're going to talk about that later. Next slide. So what are the suggested trough targets for the anti-TNFs? We've listed different guidelines or consensus statements here, but in general, for infliximab, your cutoff should be somewhere between 5 and 7. And generally, the bigger your outcome or the bigger your target, the higher the level needs to be. So for clinical remission, it's going to be one thing. Endoscopic remission, it's going to be a little bit higher. If there's fistula healing, it's going to be even higher. So for adalimumab, it's somewhere around 7 to 8. For certolizumab, it's a little bit all over the map. The AGA guidelines had recommended a cutoff of 20 micrograms per ml. Some of the other data had suggested a little bit higher. Our group at Mayo just published its online early in Crohn's and Colitis 360. We found that a cutoff of 19 was actually good for certolizumab. Next slide. So what's the concept of proactive TDM? This, of course, could take up a symposium in and of itself, and we're not going to debate all the details of proactive TDM, but I think that for the anti-TNF drugs, there's something here. It's been hard to prove, and it is curious how the retrospective studies are positive and the prospective studies are negative, but the concept here is you take a patient who's seemingly doing well, and no matter how they're doing, you're just picking a time point at which to measure the drug level. And if they have anti-drug antibodies, if they're high, you're going to either switch to a different anti-TNF or switch out of class. If their antibodies are low, you may go ahead and increase the dose of the drug. If they don't have anti-drug antibodies, if they have a high concentration, if they're in remission, you might even be able to de-escalate them a little bit. If they're therapeutic, you just continue what they're on. And if their drug level is low, this is your opportunity to maybe prevent antibodies from occurring, and you might tweak the dose of the anti-TNF. And so we're going to have a little break in a second, and we'll talk about what my colleagues do for proactive TDM. I have to say that in my practice, I'm known as a skeptic of proactive TDM, although I would say in recent years, I routinely check a week 14 infliximab level when I'm starting infliximab, although as Maria alluded to, that may be too late. And so I'm still trying to wrap my mind around, should I check it at week 8 or week 10? And we'll talk about that more in the discussion. Next slide. And so what about the SERENE trial? The SERENE CD trial looked at 2 different induction doses of adalimumab and didn't show a difference at the induction endpoint. But the other interesting aspect of the SERENE CD trial was the maintenance, where there was a clinically adjusted arm and a TDM arm, and the clinically adjusted arm incorporated not just TDM levels, but you were actually looking at symptoms and things like CRP to make a decision about adjusting the dose. And you can see that at the end of the 56-week trial, there was no difference in remission rates between the clinically adjusted and the TDM arm. So food for thought. So maybe we'll take a break here, bring back the panel, and we'll talk about some of these issues related to TDM.
Thank you, Ed. That was great. And that's always the dilemma, right? Proactive and reactive. So, and you highlighted difference in practice. And I think we're all trying to figure out what to do, when to check our levels, and what levels do we need to achieve. And so my first question to you is, you said you're doing more proactive TDM. Do you do this for all your patients, or for patients who have more severe disease, more extensive disease, patients on maybe their second biologic, even though we know that it's the first biologic that has the most effect, or maybe we should focus on the first biologic? Are you doing this in all your patients, or only in those that you're concerned about, like those that you feel might not respond that well?
For infliximab, I do it in all the patients now. I just go ahead and check. Adalimumab, I would do proactive only in maybe the patients I'm more concerned about. I don't routinely do proactive adalimumab in everybody.
Do you think it's because? Well, do you think it's because you're using infliximab in the more severe one? I wonder why.
Perhaps. And I just, and there's just not as much. With proactive TDM with adalimumab, when do you check it? And there seems to be no consensus on when that should be. Is it week 4? Is it week 6? Is it week 8? I don't know. So I think there's still a little bit of uncertainty there about that.
I agree. And Maria, any comments on that? Do you do TDM in all your patients and specific patients? And do you feel that everybody needs the same target on the induction and later during maintenance, or do you feel like people are different? We talked about perianal disease often, that maybe these are patients that require higher dose, higher drug level. Are there any other patient that you feel maybe need more? I mean, we all see patients with infliximab level of 2 during maintenance doing just fine. And, Ed was presenting, and this is, I know a few years ago, if anybody had a low level, I would panic and I'd be like, we have to adjust your dose and frequency because this is not the right level. But then now I don't panic as much as anymore, and I don't know if I'm putting my patients at risk of developing antibody or flaring later on, but I don't know if by increasing their drug level, I'm doing anything for them. So I really wonder if different patients have different need of levels, or different disease have a different need of levels. So I know I'm 50 questions in one for you, but one is, do you proactively TDM during induction for everyone, and what do you do for maintenance, and what drug level do you feel comfortable keeping? The whole point of doing proactive TDM during maintenance when the patient's doing well is to make adjustment. Do you make these adjustments, or do you hold off, or depending on the patients?
Yeah. Well, let me start by saying, I already revealed that I do proactive TDM in the infliximab patients that third induction dose, and I think that's really turned out to be. I think that would be a game changer. I actually think that waiting. I used to do it before the first maintenance dose after that 8 weeks, but then again, you don't have an opportunity to intercept those patients that have very low levels before that week 8. And so it makes a lot of sense to me. And those levels at trough before that third infusion need to be very high, either above the limit of detection of the assay, or certainly way above 20. Remember, they just got 2 doses back to back, and you're only checking it 4 weeks later. So if that isn't really, really solid, they're gonna fail by week 8. The other little thing that I'll mention now, because I don't think it'll come up, is that I learned something only recently that's crazy. And I don't know how publicly available. I didn't know this, so I'm revealing this on Twitter tonight. That there's this ginormous difference, like a really ginormous difference. I'm trying to remember the actual numbers, between giving someone 10 milligrams per kilo Q8 versus giving them 5 milligrams per kilo Q4. The 5 milligrams per kilo Q4 has nearly twice the levels at trough than the 10 Q8. Not just like a little bit more, like a whole lot more. So you get more bang for your buck. Of course, I've always argued, the infusion cost, whatever, but forgetting all that, for actual, the pharmacokinetics are much better when you give more frequent dosing, which is parenthetically why when we get the sub-Q for infliximab, that one of the biosimilars is coming out with the sub-Q, the levels actually, if you look at that, if you remember the data from DDW, the actual levels are higher than they are when you give them IV. So I think that, crazy as it is that we've had this for so long and that we're still learning things to optimize. And so therefore, that was a long-winded way of saying, if I check a trough before that week, like that third, like week 6 dose, then I shorten the interval for the next one. I don't just wait and give them a much bigger dose the next time I bring them back sooner. It sort of depends whether I bring them back in 4 weeks or 8 weeks. And then I don't have, I think the embarrassing part about being so fixed on TDM is the inability to say to people, it has to be this level. Because you're right. I think we are the ones, the first ones to publish on this, that patients with fistulizing disease, really, it's a very high bar to try to close those fistulas. It kind of makes sense, right? And actually, recently, right, Ed, was it an IBD thing that someone was presenting research on fistulas, on fistula tracts, and like looking at, what genes are expressed there. And it's like goobs and gobs of TNF are being made locally in that tissue. So again, not surprising. And then I think hot UC, especially extensive UC, sucks up anti-TNF. It's not only just the protein losing enteropathy, it's also the intensity of the inflammation that they have that is consuming a lot of TNF. These are all my personal opinions, by the way. I'm not sure I can really defend that with a lot of data. And then you said something about ileum versus colon. I've always thought of the colon as having the bigger inflammatory burden, than say, like someone with just limited ileal disease, that would be easier. But then I was reading something, I think it's published. It's just, I've seen so much data in the last, 72 hours at DDW, but I don't think it's there from there. But Gert de Haas and others reanalyzed some data set and found that the ileum was less likely to heal proportionately compared to the colon. What was that, Ed? That was not Sonic again.
Well, it was the Robarts videos
Sonic
from
again?
Sonic. Yeah, they reanalyzed them, and it's true. I think ileal ulceration, they're just harder to heal for whatever reason. I don't think we understand why.
Right. Probably other mechanisms at play. So still interesting things to learn about that.
I think this is what's making this conversation fascinating. I'm going to ask one more thing and then move on. I can't believe we've been together now for 45 minutes and we start to go more for longer. But this has been amazing. But but maybe next time we should have bottles of wine with us also. But Ed, in terms of
you don't have a bottle of wine with you?
Is this where you've been leaning on the side? I thought you were tweeting on the side. So Ed, before we move, I think we highlight the paradox, right? So for proactive TDM, retrospective studies show that it helps. We have serine data show it didn't really make a difference. Drug monitoring, we're still kind of searching for the right level, the right time, etc. How about with the neurobiologic? I often get this question a lot. Should we check for levels? Do level mean something different? Do you escalate without levels? Does it make sense? What should we do for the neuromechanism of action?
So just from the standpoint of the fact that we see fewer patients develop antibodies, to me means you probably don't, you can get away with dose escalating just based on clinical, loss of response, that you probably don't need the levels as much. Some people think, well, maybe it helps make the case for the insurance company getting approval for the escalated dose. I'm not so sure. I have to say that I've done a lot of TDM with both ustekinumab and vedolizumab. I think it's probably moderately helpful with vedolizumab, but I'm not sure for ustekinumab. And I think the whole ustekinumab data is colored by the fact that the assays are wildly different. Just not just the antibody assays, the drug level assays are wildly different. And so when you read the literature, you have to figure out, okay, which assay is it? Because the differences are more than twofold in the concentration. So it's a messy literature, I think.
Okay. Well, let's try to make it less messy next. And, we were very excited. DW CView data was presented. So I'm looking forward to hearing the data from you, Ed, and tell us about this first head-to-head study between ustekinumab and adalimumab in Crohn's disease. We had Varsity last year, and this year we have CView. I love the names, by the way. I like CView better.
That's a good one.
It's all yours.
All right, so let's see the slides. Okay, so this is the general design. So recall that these were Crohn's disease patients who were all bio-naive, and they were relatively early duration. I think the median duration was about 2.5 years. So these were not our sort of long-standing Crohn's patients with multiple surgeries, et cetera. So these were bio-naive, and they were randomized. This was a treat straight through design, so there was no re-randomization at induction. There was just the endpoint at 52 weeks. And so you either got the approved dose of ustekinumab or the approved dose of adalimumab. There was no opportunity for dose escalation, and it was double dummy, double blind, so patients had to get all those extra placebo injections if they were in the ustekinumab arm. Next slide. So the primary endpoint was clinical remission based on the CDAI score of less than 150 at week 52, and you can see that there was no significant difference. This was 64.9% with ustekinumab, 61% with adalimumab, so it was a difference of 4, and you can see it was not statistically significant. So that was the primary endpoint. Next slide. I'm not going to show you all of the secondary endpoints. I'll show you a couple of them. Here was endoscopic remission at week 52. Now, admittedly, this is a pretty high bar, SES-CD of less than or equal to 3 at week 52, and you can see it was 30.7% with adalimumab and 28.5% with ustekinumab. No significant differences. Next slide. Safety findings. I just want to point out here that overall adverse events were similar. Numerically, so SAEs, serious adverse events, were 16.4% with adalimumab and 13.1% with ustekinumab. Serious adverse events of worsening Crohn's disease were 7.2% with adalimumab and 2.6% with ustekinumab. Serious infections, 2.6% versus 2.1%. No deaths. There was one basal cell skin cancer in the adalimumab arm. You can see there were a few infusion and injection-related events, some of which occurred with the placebo infusions or injections. And then adverse events that led to study discontinuation was 11.3% with adalimumab and 6.3% with ustekinumab. Next slide. So I think we can say that they're equivalent in efficacy. Maybe there's a slight edge with ustekinumab on safety, but both drugs were effective. What else is going on for head-to-head trials? You can see a partial listing here. There is a biosimilar made by Boehringer Ingelheim that's being compared to originator adalimumab. Brazikumab, which is one of the anti-IL-23 drugs, is being compared to adalimumab in actually a registrational trial. Mirikizumab, another anti-IL-23, is being compared to ustekinumab and placebo. And then guselkumab is being compared to ustekinumab and placebo. So the last three are all anti-IL-23s. And so the interesting thing here is that relatively early on in the life cycle of these drugs, we'll already have head-to-head data, which is nice because it seems like we often get these head-to-head trials towards the middle or end of a life cycle product. And again, that's just a partial listing. I think there are more things in the works, but it's an exciting time because it's really the head-to-head studies that can really help us make some determinations about positioning drugs. And I think we'll go back to the panel at this point. We'd love to hear what everyone else thinks.
Thank you, Ed. So, I mean, I think I'm very excited that we're having head-to-head studies to help. Am I echoing for you guys? No, hopefully not. To help us really truly position therapy. So far, we've been, relying on, comparing data that's not comparable. But I think also the one part that makes me excited is I think patients will be less reluctant to enroll in clinical trial when they're not getting a placebo, right? When they're getting some form of therapy. So I think this is an exciting way moving forward. But I want to hear your thought, Ed, now that you presented the study. How would that change your practice? How, do you feel like, well, whether I use this or that, that's fine? Or, do you still have a preference for certain patients? It was interesting also to see that overall, in terms of adverse event, maybe there was not much difference, even though more patients on adalimumab stopped the drug because of adverse event than ustekinumab. So I don't know what that exactly means. Is it the severity of the side effects or etc.? But where do we go from here, and how do you apply this to your practice?
Well, I think it tells us that they're both good drugs for Crohn's disease, and I've always thought that both of these drugs. And if you think about it, at least in my practice, for Crohn's, those are probably the two drugs that I use most commonly. So I think it tells us you can use either one as a first-line agent, because these were basically first-line patients. They were all bio-naive. And I think it gets back to diagnosing your patient not only with what they have, but what drives their decision-making. And so for the risk-averse patients, ustekinumab is going to make more sense, but I still think adalimumab is a legitimate option, I think, for Crohn's Crohn's patients. I'd love to hear what you all think.
What do you think, Maria?
Yeah, no, I mean, I think it's a glass half full. Obviously, we're skirting around the issue that someone thought there were going to be a winner here in this clinical trial. Obviously, no one's going to pay for this big study, but I admire people taking risks. You know, they took a risk. Are they going to win, or they're not going to win? And in this case, I think the win is that actually the rates of remission were actually quite high, like more favorable than usual. Obviously, you can cynically imagine that it's the summation of the placebo plus the effect of the drug, right? Because there's no placebo. So, it takes into account placebo because some people are responding to placebo. But nevertheless, they work very well. They both work similarly well in this patient population. And I think then it's left us to the nuances, right? Like we can talk, does the patient have arthritis? Does the patient have psoriasis? Does the patient, have fistulizing disease? I mean, even for the fistulizing disease, the ustekinumab data doesn't look terrible for fistulizing disease. So that study, they're doing a prospective study, but I'm basing that comment on something I just saw. But I mean, it looks like it really does have an effect. Obviously, whenever people have less diarrhea, it'll improve fistula drainage, but it does seem like, ustekinumab may have an effect. And I think I believe they're doing the study, like a prospective study with MRIs and things to figure that out. So maybe, we will be using it. Yeah.
Yeah, I agree. I think it's brave to do these studies, so it's good.
Yeah.
And I think it's really given us reassurance that both drugs work very well. And so we can adapt our choice, depending on the patient characteristic and needs and preferences and values. I think that's a take-home message here that, it doesn't, I think they're both winners the way I look at it. And like you said, the clinical remission was high, but I really think that give us more freedom and more reassurance that we could use one or the other and adapt it to the patient need and preference, or the insurance preference in many cases. So I think that this study, for me, the results are positive because of that. And I always love it when everybody wins anyway. So I'm this kind of player. All right. So, we talked a lot about how we can optimize, our remission rate and our success rate. We talked about close monitoring, therapeutic drug monitoring. We talked about, how often do we need to bring patients back? But I think, the reason I always love listening to Maria is that, we also really need to think outside the box. And I think our patients want us to think outside the box. And the clinician and the researcher, everybody is looking for more answers. How can we get above this 30% of deep remission or 60% clinical remission? How can we get to this full remission in everyone? And what is missing here, and where is the future of IBD going? How can we personalize care, and how can we use other things beyond medication, in addition to medication, to improve at least the quality of life of our patient, but hopefully also their inflammatory burden? So, Maria, I'll let you take it from here.
I'll try to do my best, Aline. I have a big responsibility now for a couple of reasons. One is because it's after 9 o'clock on the East Coast. And so the only good news is that I had an espresso like this afternoon, so I'm sort of a little bit wired for sound. So I apologize in advance to the audience if I'm talking even faster than usual. All right, so you can go to the next slide. So here's the Holy Grail. Right now we can't figure out when someone's in front of us in clinic which therapy to use. We empirically we read tea leaves. We decide a little bit on like what Aline said, do they have fistulas, do they have arthritis, and that kind of thing. But ideally, we would have some way, whether it's a blood test, whether it's a DNA test. It won't be a DNA test alone, but something that will allow us to better decide whether a patient has a higher likelihood to respond to one versus another. This becomes an interesting topic now because we have other mechanisms of action, right? In the past, it was anti-TNFs or anti-TNFs. So now we have more to choose from, right? But that's still a little bit. That model on the right of your screen is really, they're seeing that now in oncology, right? But oncology, you can get the tumor, you sequence the tumor, you see what mutations are in the tumor, And although cancer is terrible and it's complicated in its own way, in that way, it has been a little easier to tackle than the complexity of what is IBD. I'm sure that'll come back to haunt me for saying that. Next slide. So this was alluded to already by Ed. This is actually from the PANTH study. I don't know who came up with that name, but it's one way in which we might be personalizing the therapy for patients. So it turns out that a third of the Caucasian population, and we actually found similar results in Hispanic patients that we just presented at DDW, are carriers of this HLA-DQ-A105 polymorphism, right? And so this is just part of our HLA. And if you have this HLA-DQ variant, which again, a third of us on this Twitter feed tonight do, you're someone highly likely to develop antibodies against infliximab. To a lesser extent, adalimumab, because we know that infliximab is more immunogenic than adalimumab. And what you can see here is on the dotted line. Okay, this is like a Kaplan-Meier of patients. If you see that Y says no anti-drug antibodies, the patients in the dotted line are patients that have that polymorphism who were given infliximab monotherapy, no thiopurine. By less than a year, right? Because you can see 300 days, almost all of them have developed antibodies to the infliximab, right? People who don't have the polymorphism and are on a thiopurine, that rate is only like 40% of them are making antibodies to infliximab anyway, so it's not like it's foolproof, but nevertheless, it would be foolhardy based on these data that I'm showing you here to start someone on infliximab monotherapy if they have this polymorphism. So, I'm not here to advocate that maybe they should be on something that is not infliximab, but I think that has to be taken into account when you're making that decision, because again, indeed, those patients are going to develop antibodies to the infliximab. So you might want to consider things that are less immunogenic, or for sure thiopurine. Next slide. Forever, people have been trying to identify things that are predictive of a lack of response to anti-TNF. And so this is a study published in Nature Medicine by a very famous investigator at Oxford, where they looked at serum samples pre-infliximab. I think they got the data from Janssen for the ACT studies that for UC, and they found that patients that were unlikely to respond had higher levels of this cytokine called oncostatin M in the serum. This is a member of the interleukin-6 family. And so, it's one test. I sort of imagine that if we ever were to use it, we'd probably have it as part of a panel with other tests to predict whether someone's less likely to respond to anti-TNFs. But this is the kind of stuff that we need to do in order to identify, okay, look, if they have high oncostatin M and they happen to have HLA-DQ, 0105, maybe this isn't someone that we would treat with an anti-TNF. Next slide. Okay, from there, one of the reasons I made the comment I did about in cancer, you can take a tumor, you can sequence it and see what the mutations are. In our world, right, in this world of IBD, we have the microbiome as a moving part. We have what's going on in blood versus what's going on in tissue. So there are lots of different things that we could be trying to assess. And investigators have already started to look at whether the microbiome can predict whether someone's going to respond to therapy. And this is a study from Ashwin and Annakrishna at MGH, demonstrating that in fact there were some microbiome elements that were correlated with a response to vedolizumab in this case, and not surprisingly, these were patients that at baseline had bacteria that were making butyrate. Right, all of you probably know that short chain fatty acids, and butyrate in particular, has a salutary effect, has an anti-inflammatory Treg inducing effect. So this isn't unbelievably surprising, but interesting nevertheless. Next slide. This is, you may have heard of the STORY study. The STORY study is a study in which patients that were in remission, doing great on infliximab, were randomized to either continue on infliximab or stop infliximab. There are all sorts of clinical correlates of who stayed well after they stopped infliximab. By the way, they were all on thiopurines at the same time. But they've also looked at what the microbiome profile was of patients who stayed in remission even though you stopped the infliximab. And so things like F. prausnitzii, which is thought to be an anti-inflammatory bacteria, if patients had that bacterium, that species in their, colonizing their intestine, they're more likely to coast and stay in remission. Whereas those patients that had more proteobacteria, these are the things like E. coli, for example, is in that proteobacteria family, those patients were more likely to relapse. So again, I do believe, especially in ulcerative colitis, actually, that the microbiome will help us predict who can safely be discontinued from their biologics and will be able to maintain their remission. Next slide. And then at Mass General, they have been collecting, specimens prospectively. They looked at patients who were in remission at the beginning of their study. They did colonoscopies, they did microbiome, blah, blah, blah. They did serum for all these different things. And then they followed them for the next 2 years, and they saw who relapsed and who did not relapse. The minority of patients relapsed, but they could tell, then going back to see what was different about those people that relapsed. Again, there were changes in the gut microbiome, like, having more proteobacteria, more fusobacteria, that correlated with them having a higher risk of relapsing in the future. So even when people are well, we could in some future, whether that's next year or next pandemic, be able to predict who are those people that are more likely to have a flare over time. And I think that would be a useful thing. Next slide. So far, the last couple of slides I've showed you are all IBD patients, right? But this is actually not about IBD. This is a study that was done in like thousands of people, an incredible study where they looked at mega data. They had all these people, normal people, not even of anything. They had all their microbiome sequenced, and they had a lot of information, like all their blood work, CBCs, what their cholesterol was, whether they were fat, they were skinny, what their lifestyle was, and all that. You can sort of see it on the legend that's on the right. And like in life, diversity of the microbiome is a good indicator of health. Actually, a more diverse microbiome is associated with better health, and in lots of ways. And as an example, IBD patients have very low diversity of their gut microbiome, probably as a result of the inflammation. So on the left are things that are negatively associated with microbial diversity. So you can see that things like having high triglycerides, having a high BMI, a lot of those things have to do with metabolic syndrome, were associated with low bacterial diversity. But what's associated with having an increase in bacterial diversity, and things that we might be able to impart on our patients? So you can see that at the bottom, the ones that have the strongest effect are eating raw fruits and vegetables, having vigorous physical activity. All those things are beneficial. And I actually do feel that, and tell my patients that they need to exercise and eat healthy and get 8 hours of sleep. But I circled the, fruits and vegetables, again, sort of in the middle of the pack. But importantly, alcohol was something that was associated with an increase in bacterial diversity. That always makes me happy when I see that. Okay, next slide. All right. The theme is what other things can we be doing to predict an outcome of a patient before it actually happens? So this is looking at NOD2. I'm proud to say, ours was the first paper describing that patients that have polymorphisms in the NOD2 gene are the ones that have fibrostenotic ileal Crohn's disease. Okay, fine. But this study showed that if you have that polymorphism and you smoke, you have 100% chance you're going to need surgery for a stricturing disease. So I think this is really cool because, NOD2 is one of the tests that is, at least in some commercially available panels, to predict what kind of Crohn's disease a patient is going to have. And this shows us that if you have that polymorphism, smoking is a really bad idea. Smoking is a bad idea anyway, but it's a particularly bad idea here. All right, next. Okay, diet. So, I hope many of you that are listening tonight actually had a chance to attend DDW virtually, and I think you could still listen to a lot of the lectures. And there was actually just an incredible amount of stuff on diet that it would be impossible to summarize. But what I wanted to kind of impart tonight is that there's the effect of, I've talked about microbiome already. There's the effect of the diet on the microbiome because, of course, we're providing food for the microbiome that's there when we eat. There's also a direct effect of diet on inflammation, and I won't have time to show you that, but that's better studied in animals than it is in humans because we do have a microbiome, right? But if you do this in germ-free mice, diet can have a direct effect on inflammation. And then finally, again, we heard at DDW a lot of talks that have to do with all the stuff that comes along for the ride in our modern Western diet, which is that if you buy a bag at your local grocery store and the expiration date is sometime in 2024, there's a lot of non-food in that food, right? So all the stuff that's coming along for the ride, emulsifiers, microparticles, and a lot of other stuff. Next slide. So this was, again, some of my favorite themes that came out from the last year or so of basic research. And this is, one of the horrible things that's happened to us is high fructose corn syrup, right? And we can talk about how all that happened, but fructose is actually often poorly absorbed. And in this is mostly done in animals, this work that I'm showing you here. And the graphs on the right, what you can see is that if you give mice, like a sort of something that causes inflammation, and you've given them a high fructose diet, their inflammation is going to be substantially worse than if they weren't on a high fructose diet. And it's mediated by the microbiome, because if you did that same experiment in germ-free mice, you wouldn't worsen them with the high fructose diet. And the investigators go on to do elegant work that has to do with whether with changes in secondary bile acids as a result of having this high fructose diet. So this is an easy message to convey to patients that they should not be drinking, soda and things that are just full of sugar, because now in this country it's all done with high fructose syrup. It's not table sugar. Next slide. We did this study, and we did a study in ulcerative colitis patients where we hypothesized that a low-fat, high-fiber diet would be beneficial. And we decided to have each person serve as his or her own control for the study, so that we gave and we catered the diet. So we kind of didn't keep them in a room and force feed them, but we delivered food to their house and made it as easy as possible for them to adhere to the diet. And so they either had 4 weeks of the low-fat diet first, followed by 4 weeks of what STAD stands for, Standard American Diet, which is kind of, I think, funny. SAD, you get it, versus the other way around. And and I just want to make a couple of points. The first is that at baseline, people are eating a lot of fat, like you would imagine a Standard American diet would be. So that's the bottom left graph. And in terms of fiber, these are ulcerative colitis patients that are in remission. These patients had almost no intake of fiber. And actually, when we asked them for how many fruits and vegetables they have on a daily basis, many of them were zero. Were eating zero fruits and vegetables over time. So it's really awful. Next slide. And so we gave them this, low-fat, high-fiber diet, and in fact, their quality of life improved, their general health questions improved, and there was a sign, at least at a systemic level, that inflammation improved. Remember, these are patients that were well already. We did have a little bit of a decrease in calprotectin, but they were by and large in remission. But even those patients in remission could be made to feel even better by having this healthier diet. All right, next slide. And so, conceptually, the way I see it is, look, we've heard from Aline, we've heard from Ed. We have amazing biologics, even though we're trying to come up with a better word than biologics, but we're leaving a lot on the table. And what are we leaving on the table? Well, we're still not targeting the microbiome, whether we're targeting the microbiome with actually microbial therapies, again, discussed at DDW, or supplementing or complementing the microbiome with the diet that we advise our patients to have, which I think has an effect on epithelial barrier function. And my feeling, and you can go to the next slide, is that I think the next big advance is not only just the big advances that we're making in diet and microbiome-based therapies, but using combinations of therapies. It's such a shame that for all intents and purposes, all these drugs, when they get approved by the FDA, are tested one at a time serially, when in point of fact, in real life, we would never normally do that, right? If you had all the money in the world, wouldn't you superimpose another drug on top of only a partially working drug? So with that, I'll shut up and have my friends come back and tell me if anything I've said has any clinical relevance.
That was fantastic. I'm a big believer in diet and lifestyle, and I think we just, it was interesting to me that for the longest time, people would say it has nothing to do with diet. And, when we have like the biggest lymphoid organ, basically like immune organ is the gut, and we're putting everything through the gut. And I do see it in my patients, patients who are on biologic and doing well, but they just they just need a little bit more. And they tell me when they start cooking their food and eating out less and eating less processed food and added sugar, they do feel better, and whether their disease is getting better. And I think you presented data, encouraging data showing that the crap that we put in us can increase the risk of inflammation, or they're feeling overall better. And I know there's a lot of interest now in diet, and there's at DW there was a presentation of the specific carbohydrate diet versus the Mediterranean diet. Didn't show an improvement in inflammation, but people felt better. I think it's all about long term, right? So your microbiome has to be like a garden, right? Constantly nourished for the right thing. And I think we don't know if you start eating healthy after you have IBD, if it's going to make a difference. But I can only think that it could make a difference. And it might not be something immediate, but it might be something more long term. And I just cannot imagine that all the additive and fake sugar that we're putting in ourselves is good for us. But I think the problem that we're having is kind of a social problem, right? We can tell people eat healthy. And of course, there are limitations. If you have a Crohn's stricture, if you have bad flare, then, we need to adjust how you're having your vegetables. You might not be able to have a big salad. So, but beside that problem, as a society, it's much cheaper to go get a bag of potato chips than to get, sweet potato and put them in the oven and have all the good fiber there. And it becomes very difficult in a busy life to be able to prep your food and avoid all these added things. So I'm going to start with Maria, because I think of either of us, me or you, I think she runs the fastest. So she has a secret for this. When I saw the ACG, running, and I was like, I can never keep up with these women, Maria and Millie. I'm like, they're too fast for me. So,
no one can keep up with Millie.
What kind of advice do you give your patients? How can we get this? Not everybody can afford organic. Not everybody can afford, all that good stuff. What can we do for our patients? What practical advice do you give them?
Yeah, I think the first kind of editorial point I'll make is that we put at the bottom of that paper that I just showed you with this low fat, high fiber diet, that we catered. The most expensive thing of doing the study was catering it, right? Was catering it for, and the reviewers were like, do you really need to cater it? It's that extra money. If you multiply what it cost us to cater it by a year, it wouldn't even come close to, it's probably one dose of a biologic, maybe 2 doses, right? So something as important as diet, even if we fed them and sent and catered it. In fact, I said to Jim during Jim Lewis, because I think, again, that study showed us that whether it's a specific carbohydrate diet or Mediterranean diet, they both did well, because for lots of reasons, probably you're taking out all the, the processed foods and all these things. We could speculate. We're feeding them. I said, we're sending them the food that takes all the stress out of it. They have the prep food, right? These busy people who might otherwise have to think, oh my God, I got to go to, Whole Foods or wherever they go shopping and cook something. They don't need to worry about that anymore. They're receiving the food at home. We're now doing a study. One of the most fundamental things is, how do you change how people eat and what they eat? Because it's, we grew up a certain way, right? We grew up a certain way. So we're doing a study now funded by Helmsley, which I'm very grateful for, where there are 3 groups. One, the Crohn's patient just gets dietary advice, like on eating low fat, high fiber. The second group, the Crohn's patient gets 8 weeks of a catered diet, but again, just gets, good luck with that. And then the third group, where the person and a significant other with whom they live get the food, but they get counseling along the way, using psychological theories of how you change behavior. And we decided on one called self-determination theory, where we get people to understand the concept, but embrace the idea for themselves that they want to do it. And then, how do you make a plan? Where are you going to go shopping? What are you going to buy when you go to the grocery store, so that we can change it more from the ground up not just us telling them, you got to go eat healthy. Because how many patients tell you, oh, I'm eating healthy, doc. I'm eating healthy. And then like you ask them, so what is it exactly that you're eating? You're like, you're afraid, you don't even want to open that Pandora's box because you're against time, right? The other patient's waiting. You're like, oh my God. Like I had someone tell me the other day, I say, well, do you eat enough fruits and vegetables? He goes, well, I have a V8. I have a V8 every day.
That's
So there's,
vegetables.
yeah, it's got vegetables. So I think that we're leaving a lot on the table. I mean, I also believe that these studies of diet shouldn't be held to the same standard of mucosal healing. Who's asking for mucosal healing? We're just, we're asking for there not to be an antagonist to mucosal healing. Because I think that in some cases, right, Ed, I think, some of the things antagonize, the effects of these drugs. And that's why I think we should be like all, speak with, again, with the confidence that, yes, we don't know exactly everything you should eat, but we know a lot of stuff that you probably shouldn't be eating.
Right. And I think you bring a good
I'll
point.
often tell, I'll often tell the patient, look, all the common sense things that your mother told you are true. Like eat home cooked food. Don't go out to dinner as much. Make sure you, just like Maria said earlier, make sure you get plenty of sleep. And it's like all those little things I do think add up in terms of lifestyle modification.
Yeah, and I think, Maria, you bring a good point that if you can show that if payers would pay for catered healthy food, it will be less expensive than having to escalate biologic. I think that maybe we achieve a miracle having dietary counseling and healthy food being covered. That would be the dream. I think we're gonna wrap it up here because I think I kept you both really late, but this was such a pleasure. Ed, it's always good to have you. I think you're one of the first supporter of Monday Night IBD, so that's always been something I always appreciated, you supporting this format and being such a wonderful teacher from on Twitter. So I learned so much from you from far, being across the country, and I really appreciate you presenting the CView data today and all the input and all the wisdom and again imparting again when good is good enough. And Maria, it was such a pleasure to have you. I know you've been resisting Twitter, but I could not help see that you were tweeting while you're presenting. My notification kept coming up. I'm like, she got it covered already after one session. So I think my goals, my treat to target have been achieved. I learned a lot from both of you. You're tweeting. Ed is doing well with us, so I really appreciate you spending the evening with us and all the the tips and things that we don't learn from just papers, that experience that you shared with us. And I think for those that are listening, I think it's important for everyone to see that when you're struggling, others are also struggling. When you're not sure, others also are not sure, and we're all trying still to figure things out and tweak things out. But the important thing is that we're doing all this with a patient in mind, and with the goal of improving the care of IBD patients. So thank you both tonight, and for our audience, make sure you fill the evaluation and get your CME credit. The website to get your CME credit is here under the slide. I'm going to say goodnight, but I want one picture for my Twitter feed, and if everybody can smile, the 80 smile. All right, thank you. Have a great night, everyone.
Thanks, Aline.
Thanks. We'll see you.